I would love to welcome Susan Hamilton, a pediatric critical care nurse practice specialist, Boston Children's Hospital, rashes and splashes, care of Peri Ostomy and feeding tube skin. And then we'll have Dr. Sandra Jane, a psychologist, individual and family counseling, adjunct clinical affiliate, School of Nursing at University of Texas at Austin, with a presentation on standing tall in the face of adversity, the power of wellness enhancing practices. So now I'd like to welcome Susan Hamilton.
Hi, everyone. Thanks for having me. Those of you that may be from the Massachusetts or Boston area, I was lucky enough to join you at one of your in-person meetings. It might be 2.5, 3 years ago now, and talked a little bit about skin care around ostomies and feeding tube sites. And so I'm back to sort of represent that and hopefully hear from you. And I'd really love for you to, chat with each other about things that have worked well for you or things that haven't along the way. So like she said, my name is Susan Hamilton. I work at Boston Children's Hospital. I'm an ICU nurse at heart, but I also am a certified wound ostomy continence nurse. I have been such for about 10 years because critical care really is an area where skin and ostomies really shine through. And so it's excellent to be able to have the expertise while also caring for critically ill children. So I just want to start with disclosures. I have no conflicts of interest. All photographs in this are used with permission, and I do not endorse any particular product brands that might be mentioned during this talk. So let's talk first about ostomies and some of the peristomal skin damage types that we might see. Commonly, you may have a chemical or contact dermatitis, as we call it, and it's related to the acidity of the output of the output from the stoma itself. And I work mostly with kids, and if you think about small children, babies, who the real estate there is so small. And there may be a mucus fistula, there may be a feeding tube, there's a scar down the middle, or maybe it's horizontal, and it's really difficult to cover all of those areas and to contain leakage and to be able to avoid these type of things from happening. Sometimes in an infant, a one-day pouch is actually a good wear time. So, acidity, the higher the ostomy, the more acidic it will be. Children tend to have adhesive issues as well. There can be lots of allergic type reactions to different types of pouches, and luckily there's a lot of companies out there that do make pouches, and so whatever pouch you start with doesn't mean it needs to be the pouch that you end up with. It's also what you put on your skin that also may cause a chemical or contact dermatitis. We'll talk more about that. And then there's also mechanical type injury or medical adhesive related injury. Anytime you pull off tape off of sensitized skin, there's a chance for trauma. We'll talk about fungal rashes a little bit related to antibiotic usage or excess moisture. Talk a little bit about product allergies, and then just briefly talk about folliculitis, more for our male counterparts who have stomas, not so much a problem in small children. So let's start with contact dermatitis. As you can see, this is a small belly of a small person. It's a double barrel ostomy. And you can see that there's that redness right where that arrow is. Actually, this picture probably doesn't do justice of just how raw that skin was. And the most difficult part about this is where that arrow is where the ostomy actually, the os puts out the stool. So that stool is obviously going to gravitate towards the skin. And if it's coming off that way, then that's why that skin is getting irritated. So what you need to do is obviously clean that skin up, but then you need to come up with ways to sort of reroute the stool output to keep it away from that area. So some things that you can do just to make the skin feel better is to use oatmeal baths. Some people get in a whole oatmeal bath, especially if they had poison ivy or something, but these are brand names here, but basically using oatmeal that is, wet and soupy. In the smaller children, we put it onto a face cloth or some kind of a cloth and just lay it on the belly, leave it there for about 10 minutes, and then wipe it off. You could then follow it with the astringent, which helps to sort of dry out weepy skin. If the skin is very open and very raw, sometimes you wouldn't tolerate the astringent because it might just feel too rough or too stingy on your skin. So you can use them in concert with each other, or you can use them separately. If you're going to use them together, it's always best to do the oatmeal, which is soothing, and then use the astringent, which is drying, and then you would go ahead and re-pouch. So then you have to develop a strategy about keeping that stool off of the abdomen. So in this case, we need to try to lift up that os to try to get the stool to come up and over. So before we start pouching, we want to do what we can to protect the skin that may still be in contact with that stool. So any of you who have ever had a contact dermatitis, I'm sure you've been taught along the way about doing a crusting procedure. This is as old as the hills, but it still works. It's easy and effective to do. So if you've cleaned the site, make sure you've dried very well. Take your powder, which if it looks fungally, and we'll look at a couple of pictures of fungal rashes, you would want to use an antifungal powder. Otherwise, you can just use a cellulose type powder, which stoma powder isn't made anymore. There's other brands that other companies have. So put that powder on and then wipe away. You just want to put on a light dusting, as they say. And then you want to take whatever skin protectant pad that you're using, and you just want to lock in that powder just by, pressing around with your skin protectant. You can do a second layer of that as well, or just a single layer, because remember, you still need to get a pouch to stick. So here's some ideas of things that you can use if you need to lift up. So if you have a receded type stoma, you may be already using a convex pouch. So convex pouches, such as the one down in the corner here, are great for being able to do that. The unfortunate thing is that for children, they don't make real strong, small convex pouches, but they do make convex rings. So a convex ring might be able to be used, or as in the upper corner here, you can use a pectin ring and either put it around the stoma or put it around the pouch, or you can also use paste to help build it up as well. So you can try any of those things to sort of bring that stool up and over and better into the pouch. So here's a picture of the same baby 4 days later after doing the oatmeal, the astringent, and then the crusting procedure, and using a ring around to try to lift up that os and get that stool to come over. And as you can see, there was in 4 days, there was good success there. So what about medical adhesive related skin injury? So everything has to have a name or initials, and so now we like to call it MARSI for medical adhesive related skin injury. And that happens, and I like this cartoon that basically it's showing a dressing coming off and the skin cells coming with it. Because sometimes the bond between the adhesive that's being used with the product is stronger than what it is between the skin layers. So you can take off some of your top layer of skin when you take an adhesive off. So your best prevention is to be slow and steady, or low and slow. When you're removing your pouch, and you can see this pouch has a tape border than the wafer, and that's something we'll talk about in a minute, but doing good skin prep and good skin removal Some of the former adhesive removers, pads, used to leave a film on the skin, and it used to make it hard for the next pouch to stick. Those products have gotten better and better, and most of them now are residue free. So if you've stayed away from an adhesive remover, you might want to see if you can get back to using one again if you're having trouble with some adhesive injury. So remember to always, hold and peel, and don't just try to take it all off. Now, as children are starting to learn to do their own care, some probably think that, I'm just going to take this off really fast, and then it hurts less. But they might be actually doing more damage to their skin. So if you're a parent of a child with an ostomy who's learning to take care of their own ostomy, helping them to do it so that not only not painful, but not causing injury. So fungal rashes, you can see on the picture that's on the left that the child has sort of this spotty rash, has some rash, maybe a little bit of contact dermatitis as well. But then if you look down into the groin, you can see all these other little satellite lesions that go all the way down into the groin. This is most likely a fungal rash. You usually see the rash, and then you see satellite pinpoint sort of pustules that come, along. If it's a small child, and especially a baby, I always suggest that parents, and this is same goes for if a child has a diaper rash, look in their mouth and see if they have thrush. If a child has thrush in their mouth and then you see a rash either on their bottom or out their stoma site, then it's probably a fungal rash because it's starting through the GI tract and out the other end. So you want to use, again, an antifungal powder. Anyone that we send home from the hospital, they always have a prescription for both a stoma-based powder and for their antifungal powder. And families are taught how to do crusting for that eventual day when they will have that fungal rash. So again, you want to do the crusting, put your light dusting of powder on, lock it in with some skin barrier, potentially put a pectin ring on to sort of support that stool coming up and over again. Also, I would say that in this child that the rash is going down into the groin as well. So this child is likely to be itchy. So you want to also treat the groin area, and I would do that with an ointment, a fungal ointment. So allergies. I don't know why, but I do know that in our teenage population here, kids who have a new ostomy, they very often have allergic reactions to the wafer of the product that they use. And we end up having to change brands or try different types of wafers for different kids. It's just, it may be part of an autoimmune disease, a part of a Crohn's or a colitis. It's hard to know why, but so at any time, even if you've been wearing the same pouch, you could develop an allergy over time as well. So you start to see the skin inflammation. And as you see, it often takes the shape of the wafer. So this one on the left, it's in the square of the wafer. So it's going to be locally red, it's going to be very itchy, and as the one on the right, it can become very weepy as well. So the first and foremost thing that you want to do is to change products. Try something different. If you're wearing a wafer that has a tape border, start with using one that doesn't have a tape border, that just has the wafer. Or try switching brands. If you belong to a care program with one of the companies, you can talk to them personally, and you can get samples of other types and try different ones until you find one. As far as cleaning that area up, I would start with that astringent soak and put it on that weepy skin for 5 or 10 minutes. DC doing everything or stop doing everything that you were doing, just in case it's not the pouch, the wafer itself. Maybe it's another product that you're using. So stop with all of your products, and then use a steroid or an antihistamine type ointment on the area, probably in concert with your provider or your ostomy nurse or whoever you're in contact with. And then your wear time on a new pouch is probably not going to be as long until you can clean up this area. And it may be a trial and error, but hopefully you can get past that and get back into perfect skin condition. Folliculitis. It's not so much of a problem with children, but it's an irritation or inflammation of the hair follicles around the pouching area. It could be caused by shaving, moisture chapping, or by medical adhesive removal. So if you're taking that off and you're damaging the hair follicles, then those hair follicles can become inflamed, and it causes an itchy, messy, uncomfortable situation. So for those that do need to exfoliate hair before to get a good pouch sale, you want to avoid using a regular razor if possible. If you do use a regular razor, it needs to be a fresh blade every time. And this may sound silly to say, but that you should not be sharing razors with anybody else in the family. That is a setup for infection. Using a clipper or an electric razor is preferable if that is the way you want to go. You know, I went on a couple of websites in the last few days because it also says, and it says on the Oley website, about using a shaving cream without moisturizer. Well, I didn't know if those actually existed. So I Googled it, and there are, but they're expensive. And I suppose it would be a trial and error as well. So if you actually use a clipper or an electric razor, that wouldn't be necessary anyway. Other people out there, you can find chats about other things that people have done to try to avoid getting folliculitis. So that's just a little primer about some of the skin issues you see with peristomal. So some pearls of wisdom that I would just say, that sign up for the care program of whatever ostomy supply company you get your products from, because they can be so helpful for you with getting you samples, giving you online education support through, you know, the journey that you're on if it's a new ostomy. And actually, you know, it may be over years, you know, you start to have prolapse or you have other sort of complications. Those care programs are there for that very reason. You know, with kids especially, people will say, well, I'm just gonna keep that pouch on until it falls off, because, you know, you never know how long the next one's going to stay on. But, you know, everyone needs to do at least a twice weekly pouch change, because you don't want to have skin compromise because you left it on just that little bit too long. So find a schedule that works for you and stick with it. And then just really, you know, own your own ostomy, own your own care. You know, be prepared, educate yourself. There's so many different things online and chat rooms and adolescent programs and those kind of things that you can get so much information from your peers as well. So let's move on to feeding tubes. So feeding tube challenges. So I went onto the Oley website to look to see what was on there for resources. And there is a feeding tube troubleshooting guide that has a lot of good information in it. So you can use your, you know, your Oley Foundation. A lot of the feeding tube companies have information out there as well. The talk earlier about feeding tubes, you know, there's a lot of different feeding tube types out there, and they all have sort of their own, you know, challenges. So things that we often see, though, is you can actually develop a pressure injury from pressure on the tube, especially if it's too tight, leakage, granulation tissue, and infection or cellulitis. So here's a picture of an adolescent on the left that you can see that there's a lot of midline scarring, and then there's this skin level tube that is almost inverted into the patient's abdomen. If I had to guess, I would say that this patient probably gained weight and that the skin level tube is now too short, and it wasn't upsized appropriately at the time. Or maybe it's a distended abdomen, but it is putting so much pressure onto the abdomen, it has actually caused a pressure injury. And then here's a tube with a bolster or a peg tube that is pressed down too tight. That flange should be able to be turned, and my guess is that that probably didn't happen, and it is creating pressure on the skin. So an appropriate size tube is important. If it's your child and your child has had the same tube from, they had it at 2 months and now they're 2 years old, and that tube length has never been increased, it's probably time to do that. You should talk to your provider about remeasuring and having an appropriate size tube put in. You should always be able to slide at least a gauze underneath, or split gauze underneath that tube to have that much room in between. So leakage can be the bane of everybody's existence, especially, again, small children with small amount of real estate, who have had many manipulations of feeding tubes. The more a feeding tube is manipulated, the more chance that it may leak. So the cartoon on the right shows a feeding tube with the balloon up against the stomach wall and then the abdomen. So that is the optimal placement for that balloon. So that balloon, if the balloon itself is not blown up adequately, or if it's failed and it's irregularly blown up, you could have a leakage around that. Or is the tube, and small children, toddlers, they don't sit still, so it's really difficult to keep potentially tubes from being having a lot of play in them. So I'll show you a few pictures of different ways to sort of support the tube from moving around a lot. Is the stoma enlarged? If a child or an adult has been having a lot of procedures, or they've been having procedures that they've gone in through the feeding tube or in through that stoma may become increasingly enlarged. If that stoma becomes enlarged, remember that that balloon eventually could slip into the tract and be in the tract and not actually in the stomach. So a provider needs to come and assess that, or go to a provider to assess that if there's a chance that you think that the balloon has actually gone into the tract and not against the stomach wall. The balloon volume, all of these companies, they have certain amounts that their balloons are supposed to take. Sometimes the balloon is underfilled, and just filling the balloon might help the problem. Other times a balloon may also malfunction, and you may not have the volume in there that you need, and in that case you're going to have to change the tube. So leakage. So this is a really bad abdomen site of a child with obviously very acidic output, and you can't totally appreciate, but that the stoma here is quite enlarged. So it's larger than the tubing itself, and so that the stomach contents are able to come up and out and onto the skin, and have basically caused a chemical burn on this child. So what do you want to do about this? Well, obviously you need to see if you can do something with the tube, but sometimes it's not actually appropriate to always just keep upsizing the tube, because the os of this is just going to keep getting bigger. So you want to try to treat the skin. Again, this crusting comes into play, that you can use an antifungal or a stoma type powder, and you can put the skin barrier on top. Then you want to use absorbent type dressings to catch that that drainage. So you can use hydrofiber ropes type dressing that you could put around the tube that will help, or you can use a foam type dressing that can absorb the drainage as well. You also can use the oatmeal for comfort and the astringent for drying it out. Then if that tube really, if the stoma is quite big and the output is quite acidic, there may come a time that they would have to take the tube out and actually pouch that and see if they could get some shrinkage of that stoma size. But then, of course, that means that your child or yourself is not being fed, which might be, problematic in itself. So here's a few pictures of feeding tubes that are stabilized. Different companies have different recommendations about dressings. And when a tube is been in place for a long time, a lot of people say that it's not necessary to have a dressing. You need to figure out for yourself what's comfortable. And I would say if you're talking about a child or a toddler, that the tube absolutely needs to be stabilized, whether it's a tape, a gauze and a tape, or whether it's a securement device, as in the one on the top right, or whether it's covering it. Some kids are just very curious and like to pull things. So, hiding it, onesies, anything that keeps a child from being able to get their hands in and play with things. So the one on the corner actually has an excessive amount of tape on it. I wouldn't suggest actually using at this point silk tape on sensitive abdomens, but tapes that have silicone in them are perfectly fine, or other types of securement devices. So here's a picture again of a patient with very severe leakage. So very frequent dressings will need to be done. And as I had just said about this tube, it now has been taken out, and try to shrink it down. If that doesn't happen over a course of, say, 3 to 7 days, then eventually this might need to be recited or revised. So this needs to be seen by a provider and dealt with. So granulation tissue, everyone who's on this call who has a feeding tube has probably dealt with granulation tissue at some point. Granulation tissue is actually a normal physiologic response to having plastic in your body, that it's sort of the growth of new capillaries that just sort of react to the plastic. And they can be large and annoying, such as the one on the bottom, or they could just be small and, not really bothersome, such as the one on the top. They can become worse as if you have a tube that has a lot of free movement, or it's improperly fit or stabilized. So, your goal is to try to avoid it, but try to avoid it becoming large and cumbersome, such as the one on the bottom here. So again, stabilization is really the name of the game in trying to keep this from proliferating. Topical treatments should always be in consultation with a provider. You can use a foam dressing that contains silver. Silver sometimes will just sort of help calm the granulation tissue down. A steroid cream such as triamcinolone can be used. That shouldn't be used just endlessly though. A trial of about 2 weeks usually is adequate. And then silver nitrate. So here's a picture of a tube being silver nitrated. I've seen a lot of scary silver nitrate applications. And so I just caution you that that it be done gently. And I actually, if a patient is in-house, I try to just do sections of it and not try to take off all the granulation tissue at once, because the silver nitrate will also get onto the intact skin and potentially cause skin breakdown. So anytime silver nitrate's being done, you should put Vaseline around the good skin to protect it, and then just do small amounts of of the silver nitrate. If you are in the hospital and they send you home with silver nitrate, or you're able to get a prescription for it, just remember that this is a poisonous thing, in that you have to keep it away from small children, and you have to dispose of it properly as well. So if you're going to dispose of it, you should wet it to inactivate it before it's thrown away. And again, also, I remember there was an instance that a patient was sent home with it where I work, and the mother mistook it to be a Q-tip, and she did G-tube care a couple days in a row with the product, and caused a pretty serious burn around the G-tube site. So always make sure that you understand what the product is and why you're using it. It also can be removed surgically if it becomes a lot. I just wanted to say one quick word about gastric versus granulation tissue. You may see sort of what's on the left here, that there's this really red beefy, that the feeding tube site almost looks like it's an ostomy. That may not be just granulation tissue. That may be true gastric tissue. That may be overgrowth of gastric tissue that has come up through the tract, especially in those that may have procedures through that site, that the gastric tissue can grow up and over. It appears to be more beefy red. It appears to be more shiny. And the big thing is that it generally doesn't respond to granulation treatments. So you can silver nitrate the heck out of it, and you will never really make progress. So if you or your child has this looking tissue and it's been treated multiple times, ask your provider if they think that this may not be granulation and that it may actually be gastric tissue. If it's persistent and it's causing leakage or other problems, it may mean that you need to have a revision of your feeding tube. So just think about, if you've had a chronic problem and then it's not getting better, is this really not granulation tissue, such as down on the right, that tends to look more pink and bumpy and irregular? So just briefly, I'll just go through cellulitis. So you can see this redness around this tube, and it's not horrible, but if it wasn't there yesterday and it's there today, then and it doesn't look rashy per se, and it feels warm, then it may be cellulitis. It's caused by a bacterial overgrowth at the site. So you do need to talk to a provider. You should outline the erythema if you can. You want to watch for any type of drainage or malodorous leakage. So I think the most important thing with cellulitis is actually preventing it. So just a few pearls that I'm sure that you're all very well aware of is making sure that you wash your hands before mixing any formula, always using clean bowls, measuring cups and spoons. If you're using formula in cans, make sure you wash the top of the cans before you open it. Always store your formula in a clean container. You want to always cover the end of your feeding tube when disconnecting. You don't want it just sort of flapping in the breeze, because it will get contaminated. And then always be changing out your feeding tube extension on a regular basis. If you are washing in between, using just gentle soap and then letting it air dry is probably the best thing to do. So in conclusion, issues can arise at any time, and you just want to be prepared. You want to know that you have the things that you need available to you, although with Amazon you can have it in 12 hours anyway. But act quickly. Don't let things sort of get beyond control. Know your resources. Who are you going to call? Do you need to talk to your ostomy company? Do you need to talk to a care provider? Or is it just something that you feel like you can Google? So, I just like with ostomy, sort of own your care. So this is one of my little friends who had an ostomy for a while. He is now 4 years old and is doing beautifully. So thanks for your interest and your participation today. And if anyone has any questions, feel free to put them in the chat and I'll try to answer them.
That was fantastic, Susan. Thank you so much for presenting for us again. Your presentations are always so informative. We do have one in the chat. It says, can you, whoops, I just moved my, can you clarify again when you use antifungal ointment versus powder?
Okay, so antifungal ointment is, you can't really use it if you're pouching because your pouch will not stick. So if you're talking about around a stool stoma, you're going to have to use powder and locking it in with a skin barrier so that your appliance will still stick. If you're talking about around a feeding tube, it's appropriate to use ointment or cream, whatever your provider, writes you for, because you don't have to worry about pouching it. So that can be a little bit more effective in those types of situations.
Great. Do we have any other questions for Susan? I don't see any in the chat now, but if any pop up, I'm happy to send them along. Oh, we do have another one coming up. How often do you recommend reusing 60 milliliter syringes and G-tube extension sets? I've had parents provide hardly any.
Yeah, that's the biggest problem is what insurance companies are willing to give. Some are very generous, some are not. It all depends on a person's insurance and whether they're under a state guided insurance. So we always try to advocate and write prescriptions for the most amount, pretty much like one per day, and they may get half of that. And over time, we always tell families to sort of hoard what they don't use, so that they start to build up a little,
Of course.
a little cadre in some closet in their house somewhere. So I don't know the right answer because it's different for everybody, but as long as you're washing and drying well, you can use, I would say, for up to a week.
Fantastic. We'll take one more question before we'll cut to a quick break before our last presentation. And we have regarding barrier cream around enteral feeding site, why are they typically not recommended for general preventative use?
So all of the I'm sorry, say again, was it barrier cream or was it barrier?
Barrier cream.
Barrier cream.
Correct. Yep.
I don't think that there's a contraindication to that, but if you're not having a problem, it's probably best not to use anything until you need it, so that you can then use other products around when you do have a problem. I don't tell a family that they can or cannot use any particular product. If it is working for your child and it's helping you ward off, that eventual rash, then I think that it's fine to use.
Great. Fantastic. Thank you so much, Susan. I really appreciate you sharing your expertise with us today.